Bismillahirrahmanirrahim. Now we are going to discuss the pharmacokinetics second part, that is the distribution step. So if you have any question regarding this lecture or the last lecture or upcoming lecture, you can simply type your question in the comment box, or you can ask me by the mail me the ask to the callme@gmail.com. So I will try my best to answer as soon as possible. So just look at the pharmacokinetics whole idea. So in the last lecture I shown this animation. So intestine is here. So your drug is in the first way, it move in the your GIT tract. So then it absorbs into the blood vessel. So this is our first step. If it's intravenous, so it no need for the absorption. So the next step after the absorption is the distribution. Distribution means drug is going to distribute into all the body, because the drug only cannot reach the target tissue in one way, because our blood is going throughout the body, means our drug is also going throughout the body. So let's see, this drug is distributing throughout the body. It can be reached into actual target tissue. Other tissue also reaches another tissue where they cause the side effect. In the liver, in the kidney. So target tissue perform the actual job, therapeutic effect. So and in the other tissues they cause the adverse effect, which you call also the side effect. In the liver, where they metabolize, and by the kidney they are going to be excreted. So we have two parts, pharmacokinetics and the pharmacodynamics. So pharmacokinetics involve the absorption, distribution, metabolism, excretion, while the pharmacodynamics is the therapeutic effect or the adverse effect or any action of drug which can do. So drug movement and the drug power. So now we are going to look at the distribution. So distribution, because drug has to, our concern is they perform the therapeutic effect, but they can reach throughout the body, and there it's not easier. So let's look at the distribution. How we can define it? We define it, it's a reversible step in which our drug transfer from one side to another side within the body. So it's a passive process between the blood and the extracellular compartment. So means your drug is moving between the blood and it can go to the extracellular volume. For example, here is blood, so it can go to the extracellular volume where they are found different tissues are present. So in this way, and they can go back here. So this is totally passive process, is dependent upon concentration gradient. If your concentration is more in the blood, it can go to the tissue. If it's more in the tissue, it can go back to the blood. So it is important for the onset, the intensity and the duration of your action. So because if it's remain in the blood for longer time, it can perform action for the longer time. It's because when it reaches at the specific concentration, it performs the job, we can say onset, then the intensity of the action. So it's totally dependent upon the distribution. So now if you look at the drug distribution, it's not distribute equally, as your blood is not distributing equally. Those organs which have more blood supply, mean they will take more drug, and the part which has poor vascular age, you can say, they have lower drug. Let's see what are those organs. For example, they initially rapid go into your well vascular age: liver, heart, lungs, brain, and kidney, while they delayed go to your poor vascular age: skeletal muscle, bone, and the fat. So if you look at the graphical representation, here is on this side axis is time, on this side drug distribution. So for example, drug is moving coming out of the blood. So as they move out of the blood, so first they are going to distribute, then they are metabolizing and they excreting. So all these processes are going on. So where this blood is this drug is going to distribute, first they go into the well vascular age organ. So this should be, for example, brain, and then later on it's going into your skeletal muscle. Mean because they are poor vascularized, so you can see like that. So later they go into skeletal muscle. First they go into well vascularized organ like brain, or if it's liver, heart, lung. So as you mentioned, it totally depends on the blood. So let's see what are the factors which actually affect your drug distribution. It depends upon the cardiac output, how much blood is going to a specific tissue. So cardiac output, plasma protein binding, cellular reservoir, and your volume of distribution and the tissue barrier. We have to discuss all these points. So first start from the cardiac output. If I ask you how much blood is going to your lungs, what is cardiac output toward the lungs? You may be thinking 100% because all the blood coming from the heart is going to liver. Deoxygenated blood totally going to your only one organ, that is the lungs. So that's why for the lungs it's 100%. So if we as it's distributed, so if you look at the liver, 30% of your blood is going to your liver because your GAT whole blood is via the portal circulation enter into the liver. So this 25% which is mentioned here for the gastrointestinal tract is also going to your liver. So overall 30% I think is the cardiac output is going to the liver. Mean drug is same in the same manner they are going to the distributing throughout the tissue. So skeletal muscle they have 25%, and your cerebral, you can say brain, and 5% is going to the coronary, mean heart, and cerebral mean brain. Okay, so it's very straightforward. So now let's look at the plasma protein binding. So it's reversible step in which drug transfer from one side to other. Plasma protein binding. So let's see, because your drug move in a bound form or free form. So if it's bound with the protein like this, it's reversible as I mentioned. If it's bound, it is inactive form. If it's free form, that is your active form. So it can bound not for permanent. It's a reversible step. Just remain the reversible step. So it can bound and it can go back to free form. Now, plasma protein, what are those plasma proteins? You, of course, thinking the albumin, globulin, apoprotein, glycoprotein. But the major one is your albumin, because your more than 50% of plasma protein is the albumin, so your drug is bound to the albumin, simple. So globulin, apoprotein, glycose, especially for the this lipophilic, or you can say this steroid nature drug. Okay, so what are the factors which define how my drug is going to bind? So it's depending upon the amount of drug and your affinity, how easily it can bind with your drug. If its amount is more, its affinity is more, and plasma protein binding capacity is present. For example, if it's already one drug, it's for example it's 100% filled. So if you give more drug, it cannot bond with the that plasma protein. So it come in free form. So it may cause the toxicity. So plasma protein binding capacity should be present. There should be affinity. There should be amount. So almost more than 60% your drug is in bound form. If you find your drug is less than the 60%, mean you of course thinking the hypoalbuminemia, mean your albumin level is low, mean your drug is coming back to the free form. So it's commonly in the hepatic or the renal dysfunction. Hepatic mean if it's hepatic mean your synthesis of albumin is going to decrease, or if it's a renal problem mean it's more excreted. So overall your albumin level is going down. So it's that's why your free form of the drug is going to increase. So there is always competition for the drug to the binding. So for example, if you look at the common example, sulfonamide displace the bilirubin. So if it displaces the bilirubin, mean what? your bilirubin level is going to high increase in your blood. Mean what? It can lead to jaundice. So in the neonates, especially carnicitaris or the bilirubin encephalopathy or the carnicitaris mean it's a jaundice. It can mean your bilirubin level is going to up because sulfonamide is bound to that plasma protein where bilirubin has to bind. So as they displace, mean the free drug is going to increase, they cause problem. So this is common in the your neonates, especially sulfonamide is an antibiotic which is commonly used, especially a nuclear synthesis inhibitor we consider them. Okay, so sulfonamide also displaces the warfarin, mean warfarin level is going to high. Warfarin level is going to high mean warfarin toxicity, which is anticoagulant drug, warfarin. So if your anticoagulant is going to increase, mean you may suffer from bleeding. So these are very common things you need to consider that. Now let's see how the plasma protein binding is happening. Albumin, globulin, apoprotein, glycogen. So these are the things. So let's see. Here is your plasma. Here is your the capillary wall, and this is your ECF, and here is your target cell. So this is plasma. So in the target cell, what you can see the receptor. Plasma, for example, here is your drug and plasma protein. So this is bound for first step. They have come to free form. So in this way, then they come out of the capillary wall, come into the ECF, and then cross the plasma membrane, enter into the target cell. If they can also bind with the plasma protein. If the receptor is present, so they can perform the job. Okay, as I mentioned, just remember they are the reversible process. So if it's bound, it can go back to the plasma again. So like this, they are going back and also can move in the plasma in bound form. Finally, they have to excrete it. Okay, so this is the whole process how they bound and come in free form. Okay, now the next step, which is a tissue reservoir. Your many drug accumulate intercellular in the muscle, liver, and other cells. So it's depending upon the affinity is protein, phospholipid, and nucleoprotein. So these factor protein, the phospholipid, nucleoprotein, which is present in the cell, in the muscle, in the liver. So they actually take this drug, and your drug is bound with this component, protein, phospholipid, and nucleoprotein. So like this, for example, if you look at quinacorin, which is anti-malaria drug, it's stored in the liver. It's several thousand times more than your plasma. Okay, so you can see how my drug is going to store in the liver. Now, phenobarbital, it's going to store in the fats. Tetracycline, heavy metal, they are stored on the bone crystal surface. And if you look at the toxic agent like lead, radium, and which is going to store in the bone. Okay. Now, the next step, that is volume of distribution. It's actually apparent volume. It's not actual volume. It's a amount of drug appear to be dispersed in the given blood concentration. No, it's confusing. A lot of children are confused. I'm just going to ask you a simple question. If you answer me, you will, inshallah, got this concept. Let's say if I ask you, I have 50 mg drug or solute. If I put into 1 liter, how much concentration I got? You are of course thinking, if I put into this, so our concentration will be 50 mg per liter. If this drug is going into 2 liter, what will be your concentration? Of course, because it's going to 2 liter, means it's going to become 25 mg per liter. So because your drug is going to distribute also into the blood volume. So this volume here is 2 liter. So we need to go think what are the volume where our drug has to go. So that's why this is apparent volume, which amount or dose of drug that is going to appear in the blood concentration. So our drug, where what are the spaces where drug can go. Let's see the example. I'm just going to recall your physiology, because if you unable to understand that, it may be confusing. Let's suppose here is your blood vessel. Okay. So these are, for example, your different blood cells are moving in that cell. Okay. Now, out of this blood vessel, what is present? For example, here is different tissues are present here. Okay. Different tissues are present here. Now, let's suppose I send a drug like this. Our drug, first they can come into the plasma. So this is number one. You may be thinking it can come into this cell, so it can cross the membrane. The other way, it may cross this plasma membrane, come out of the plasma membrane and coming into this interstitial fluid. So this drug can enter into this tissue. So you can see, if this drug is only limited to the plasma, mean their volume is less. Oh, for example, 3 liter for your plasma is present. So if this drug is coming out of the membrane, so it's limited for those drugs which are hydrophilic, they are larger molecular size, so they cannot come out of this blood vessel. So they remain in the plasma, so their volume of distribution is 3 liter. Other drug which can come out of the plasma, come into the interstitial fluid, so their volume of distribution is going to increase. These are hydrophilic but in smaller size. The other drug which can enter into the cell, because they can cross the membrane of the cell of blood cell, and they can also enter into the tissue. So their volume of distribution is going to increase more. So in this way, just apply this concept. So these are very lipophilic, and the smaller molecular, smaller size drug, they can enter into tissue. So the next thing, if you consider overall, for example, a 70 kg person, if you want to check the volume, if you check the fluid, it's 42 liter almost. So, but some drug you may see they have volume of distribution 2000, 1000. Is it possible? No. I have to check the drug concentration in the plasma, but my drug is going into the tissue where they bound. So it's not useful for me. So I only check the plasma concentration, how my drug is in the plasma. If it's bound, for example, if I give for example, if it's mentioned 2000 liter, the volume of distribution is 2000, it means your almost 1900 and almost 50 plus drug is going to bound into tissue. It's not present in the plasma or in any fluid. So that's why, according to this distribution, our drug volume of distribution is different for different drugs. Let's see the example. If it is a highly ionized, it's water soluble, so and high molecular weight, so it cannot cross a blood vessel, as I mentioned. So their volume of distribution is very low, only 3 liter only because it's plasma. If your drug is highly ionized, but low molecular weight, so some reach into the interstitial fluid, as I mentioned. So their volume of distribution is 40 liter, plasma plus the interstitial fluid. And if the other drug that is unionized and lipid soluble and molecular weight is low, so they can enter into the cell, so their volume of distribution is 42 liter. ECF is also, it's not a ISF is ECl. Okay, so the other drug which is unionized and low, but they are high affinity for the tissue, mean they're bound in the tissue, not moving in the tissue, they are bound in the tissue. So their volume of distribution will be more than the 42 liter. It's totally dependent upon the chemical composition of your drug. Okay, so let's check the volume of distribution, how we can check out. It's normally this is formula is applied volume of distribution amount over concentration at 0, but I think you use this thing, concentration amount per volume. For example, if you want to check out the amount is 50 mg, as I mentioned 50 mg, if the volume of distribution is 3 liters, so just easier, 50 over 3 liters over 3. In this way you can calculate your concentration. So we need to check out the different question. So why I mentioned the concentration at 0, because at 0 time, because it varies with the time. As you time pass, your drug is going to distribute in different tissue. Okay. Now what this tell, you can see the concentration is inversely related to volume of distribution, and it's directly related to dose. If you give more dose, your concentration is going to rise. If you give less dose, your concentration is going to decrease. Same thing if your volume of distribution is larger, means your concentration is less. If it's high plasma protein binding, what will happen? Your volume of distribution is going to down, because if it's high plasma protein binding, means your drug is not going out of the plasma, means it's totally present in the plasma, means that's why their volume of distribution is low. Free drug, what will happen? If free drug enter in tissue, what will happen? If your free drug enter into blood, what will happen? If your free drug is going into tissue, mean it's going out of the plasma, mean your volume of distribution is going to rise. But if it's come back to the free drug, come back to the blood, mean what? Your volume of distribution is less, because you need to less amount of more drug to maintain your plasma concentration, because some drug is already present in the blood. So like this, for example, these are very important concepts. For example, verapamil or quinidine, they displace a digoxin from tissue. So as they displace digoxin from tissue, mean digoxin come back to the blood, mean you need less amount of digoxin for the next dose, because some digoxin has come back to your plasma, so volume of distribution has been decreased. Okay. Now this is, I think you should be covered this. Now the next thing is where this drug can distribute. Two important factors, that is blood-uterine barrier and blood-brain barrier. Uterine means your placenta, and you can say, and blood-brain barrier. So because only small and lipophilic, they can cross this barrier, and so we should be careful which drug we should give for the pregnant woman, which should avoid it. For example, heparin and warfarin. These are two examples, heparin and warfarin. Both are anticoagulant. What will be your choice? I give you some hint. It's a high molecular weight heparin, while the warfarin is small and lipophilic. Which anticoagulant you will prescribe to the pregnant woman? Of course, you thinking right, the heparin. Why heparin? Because heparin is a high molecular weight, it's a charge, it cannot go into the placenta, it don't affect the baby. So that's why our heparin is changed in the pregnancy, causes no birth defect, because we don't need the anticoagulation or you can say bleeding in the baby. Okay, so same thing is happening, blood-brain barrier. So only small and lipophilic, as they go to placenta, I think it should here should be mentioned brain. Okay, brain. Okay. So, for example, PTU and methimazole. It's not. What are these? These are for the hypothyroid patient. If you want to give a person who is the has the PTU and methimazole, if it's a pregnant woman, what you should give? PTU or the methimazole? Let's see. 90% PTU is bound. 10% is your methimazole is bound. So if it's more bound form, means it's less of a free drug. So the less free is more safe as compared to the more free drug. If it's more free, means it's more active. It can cause the problem. It can go into the your baby. So that's why PTU is chasing the pregnancy, and so they cause no effect. Otherwise, if you give the methimazole, for example, it can go to the baby, where baby is not a hyperthyroid patient, so where they cause the creatinism, mean their brain is not developed properly. So we should be careful regarding all these concerns. Now, one another challenging and the very practical question, that is the loading dose and your maintenance dose. So two doses. It's a loading dose is actually a one big bolus which we initially give to quickly gain the plasma concentration of drug to a therapeutic level. While the maintenance dose, these are doses given which aim to maintain a therapeutic concentration of drug. So let's see with this graph, which I think it is more helpful. For example, here we go. On this side, drug concentration on this side, I'm showing the time in 1, 2, 3, 4, 5, 6, 7. Okay, let's see. I'm going the intermediate doses. For example, if I give patient drug 100 mg, for example, what will happen after the first half life? It go back to the 50. Now I give the second dose. Now the concentration reaches into 150. If it after half life, what will happen? It go back to 75. Then I give the other 100. It reaches to the 175. Then go back to the 87.5. So this process continue. 187.5, 94, and no 194 and 97. 100. So eventually this process continues. Eventually what will happen? It reaches to 200, which and come back to the 100. So after this concentration will be more than the 100 in the plasma. So you can see, one is this process. I want the 200 mg concentration in the body. So one is this approach. Other is, so in this what you can see, if you see after the 4 and 5, I think your half-life, your drug is more than the 97%. Mean it's quite relevant, which I need. Okay, more than 97%. So that's why its steady state concentration is maintained. After this, because 200, 100, 200, 100. So this process continues. So after 3.3, you will see it's your steady state concentration has been more than the 90%. So if you see, if you have shorter half-life, it's rapidly reach the steady state concentration. If it's a larger half-life, it takes days and weeks to reach the steady state. Let's say if, for example, if drug has, in this case, has 1 hour, how many hours we need to take? For example, we need 5 hours to maintain the steady state concentration. If another drug which has, for example, whose half-life is 1 day, what will happen? Means you need 5 days to maintain the steady state concentration by the maintenance dose. Okay, so that's why if your half-life is longer, means it takes more days and weeks to maintain the steady state concentration. If it's shorter, it rapidly reaches the steady state concentration. Okay, I think this concept should be clear. Now let's compare with the loaded dose. What will happen? For example, if I give patient, now let's look at the loaded dose. What is happening in the loaded dose? So in this case, you give a big bolus. For example, you have given 200 direct. As you give 200, what will happen next? It come back to the 100 after the first supply. So then you give 100, it reaches 200, then go back to 100. So this story continues. So what you can observe here, you can see. So you can see first you have given 200 big bolus to maintain the actual this concentration. After this, you have just continued the maintenance dose of 100. So this first big bolus is actually considered as the loading dose. So first big bolus dose given initially to quickly get the plasma concentration of drug at the therapeutic level, that is the loading dose. So it's totally dependent on the volume of distribution. You just need to know the volume of distribution, and you need to know the target. So multiply the, for example, 3 liter needed, and in this case, for example, 2 liter. If it's a 2 liter or 3 liter, so simply multiply the loading dose. For the loading dose, simply multiply volume of distribution by the steady state concentration. So it's simple. So other way that is shown here is constant infusion, where you want to get the steady state concentration. So I think this is clear. So its volume of distribution is important for the loading dose, while in case of maintenance dose, you need to think of the clearance rate and the half-life, because half-life is affecting the maintenance dose. Because if you need to, you can say, recharge that part which has been gone. Okay, so just some example. Loading dose is better target concentration multiplied by the volume of distribution. So let's see, our target is 25. What you will see, 25 mg per liter, and volume of distribution is just 200 liter. So calculate the loading dose. Simple. Multiply both these things. 25 multiplied by 200, your result will be the 5000 mg. So this is your loading dose in this condition. So this is simple question, but sometimes it's complicated. Like this, you have target concentration at 25 mg, but volume of distribution is 0.5 liter per kg, and patient weight is 70 kg. Calculate loading dose. Now I am going to start. So 0.5 liter per kg. It's not for the complete whole body. So it's and the patient weight is also given. So simply, first you need to calculate the volume of distribution for the its total body. So by step 1, step 2 for us. So 0.5 multiplied by 70. So that is a 35 liter. Now simple. 25 multiplied by 35. 875 mg. So for the maintenance dose, so target average steady state concentration is 25 mg per liter, and the clearance is, for example, 1.5 liter per hour. So now calculate the maintenance dose for the per hour. Simple. These both things are given. So simply multiply 25 multiplied by 1.5, 37.5 mg per hour. Is it possible to give a patient dose per hour? Of course, it's a difficult process. So you go for the per day calculation. How much you dose should give per day. So for this, you simply multiply by 24 because it's a per hour. So multiply by 24 hours. So 900 mg. Now you can easily calculate the doses. So if you prescribe the one dose, you should give the 900 mg. If you go for the 2 doses, mean 450, for 3 doses 225. Okay, so in this way you can calculate your dosage per day. So I think this calculation which I have mentioned, this is for those drugs which have bioavailability 100%, mean intravenous. So for the orally administered drug, you must need to divide this formula by F, mean your bioavailability. So if it's a 50 or 0.5 or 0.6, 0.8, whatever biovolume is given, simply divide this. So this is for simple calculation. Okay. Now, redistribution, very important concept regarding the clinical point as well as the step 1 example. Your highly lipophilic drug redistribute into fat after the elimination. You know better, only the highly lipophilic can enter into the CNS. That's good. The next step, what will happen? You have given anesthesia to a patient. You have seen after 1 or 2 minutes, he regain his sense. What is mechanism here? Just look at it. Here is fat, here is blood, on this side is the CNS, and this is your blood-brain barrier. So what's happening? You have given anesthesia or any drug which is highly lipophilic in nature, as the CNS is your highly vascular, so rapidly drug go into the CNS. After this, what will happen next? Your drug, some small part of drug is going to fat. So as they rapidly go into the CNS, because its a distribution is a reversible process, so this drug can come back to the blood because it is highly lipophilic, so it can easily go back. So what will happen as after this drug can be distributed to the your fat. So this process was the first distribution. This red line, this shows the redistribution. It's coming back. So that's why as this drug is come out of the CNS, so patient come out of the anesthesia. So that's why we give another anesthesia, continuously give the anesthesia until this fat is become saturated. So our drug remain in the CNS for the longer period, so we can continue our process. So it's a very important concept. Okay. So duration of action depends redistributed instead of the half-life, because normally we calculate with the half-life, but in this case depending upon the redistribution. Now I think this session is over. We meet with the next session. Thank you very much. If you have any question, you can simply comment me.